I'm going to talk to you a little bit. I want to take you back to healthcare and what it was like before. And my colleagues over here will excuse me because I'm going to caricature how healthcare, in particular medicine, worked. Now, all doctors are trained principally, especially 20 years ago, in trying to diagnose organic disease. They want to look for the cause of the condition. So typically what would happen, somebody would appear, normally referred by a general practitioner. They would have complaints, what we would call symptoms. And then you would go and see the specialist, my colleagues over here, and what they would do is look very carefully to see whether they could diagnose it. And you've heard some of the issues in diagnosis here. And then they would suggest a course of treatment. And 30 years ago, the issue really was cure. Can we resolve this? Can it get it to go away? With chronic conditions, it doesn't go away. And the assumption is that you really have to live with the condition. 20 years ago, we would never be in a room like this with patients and their relatives and their friends. The key issue was around cure and the management of symptoms. What didn't happen 20 years ago was listening beyond the symptoms. How are these symptoms influencing you and your life? And that has completely and radically changed these days. So I did a lot of work in cardiac disease, working with cardiac surgeons, and the joke was, I said, you guys are great. You are very organic, you repair the heart, but you don't think about the patient. What happens afterwards? How do they recover? How do they deal with it? Do the symptoms come back? How's their lives changed with the symptoms? And that's what's really nice about it, is the role, what I would call, in a kind of popular sense, patient power. Patients are now intimately involved throughout the research process. And Daniel indicated to you very clearly, we want to know what you want to research on. Because a lot of my colleagues, with great respect and correctly, were and are, some of them still, only interested in cure. They're not interested in, to that extent, in the management of the condition and its impact on people who have it. So what is interesting, and what we do in my group, is we work systematically to find out what the impact of a condition is on patients. And instead of just having the simple exchange in the consulting room, we would group patients together in a systematic way where we'd give them particular questionnaires, a large group of patients completing these to look at variability, as well as interviews where patients can raise all sorts of things. And we do know the close interaction between symptoms and outcome. But the key variable here is the fact that it is hugely different amongst different patients. And I'll tell you a little story about this. Some patients deal with it psychologically very different to the way other patients do. And that influences their quality of life. So I was in my office and I got this letter from a rheumatologist. I couldn't say anything about my colleagues here, so I'll use a different domain. And the referral went like this. Mrs. X has severe arthritis and should be in lots of pain, but she goes walking every weekend. Can you please treat? So here's a dilemma for me. What do? Do I say to this patient, stop walking, you should be in pain? So my solution was that I rather went to speak to my colleague. And I just showed him the data about the variable impact of quality of life on different conditions. And the same is true of blepharospasm. We know when you put people together and you examine them, there is a clear impact of quality of life. And it's quality of life both in a practical sense, activities of daily living, and there's stress effects, and then there are emotional effects. And one needs to be clear about the cycle between those. And my colleague before indicated that very clearly. Emotional impact affects your symptoms in general. So dealing with the emotions and finding tools and techniques to deal with the emotions has a double effect. One, it has the potential to reduce symptoms. Two, it has the effect, again, potentially, to reduce the impact of your condition on quality of life. So we design lots of interventions to try and influence the outcome. And my colleagues who I work with, and Daniel and others, are interested not only in controlling the symptoms, but how do we impact on patients' lives? And sitting then in between symptoms, and you'll know this from all sorts of places. I mean, some of you might think back when you were writing exams. If you became too stressed by it, your performance went down. If you were not stressed at all, you probably were a little too casual about it. So you do need to get stress up, but it needs to be productive to allow you to deal with things. So the key issue then is sitting in between symptoms and your condition on one hand, and quality of life on the other hand, are all these issues about how do I cope with it? Are other people helping me? Are indeed other people undermining me? Are there practical things I can do in my environment to improve my quality of life? Is there assistance I can get to improve those outcomes? So it's those areas which are absolutely critical, because if I showed you the data of different kinds of people in terms of their mood, emotion, and their quality of life, the range is massive. Lots of individual differences. So what we do in my group is we look particularly at that, and we design interventions, and we work closely with our clinical colleagues who are treating the condition, and we share interests about the nature of the condition, and indeed its impact on quality of life, and indeed what we can do about it. So one of the issues where you'll see where my colleague Sadie has a study that she's outlining, for those patients who come in and receive botulinum toxin for their blepharospasm, there's a lot of evidence to suggest in many areas that what I call, unfairly, again, I can be unfair to my colleagues, they're used to it, what I call the 3-month or 6-month ritual outpatient appointment doesn't coincide with how patients' symptoms are affecting them. So we have a study. We always need the evidence to demonstrate whether this is better, where patients say, I think it's time I saw my ophthalmologist. It's time I had another botulinum toxin condition. Having control over your treatment is an area which is demonstrably, in many areas, been evidence-based to show that it improves your sense of your quality of care, your sense about how you can manage your condition. And that's the study that we're going to do now. So, as a psychologist, you know, whenever they show psychologists in cartoons, they have beards. I fulfill that criteria. I'm very happy to talk more about it, and it's an absolute delight to be here and to see you all. Thank you very much.